Well, it's a pleasure to be back with you and sharing another update on COVID-19 therapeutics. This is our September 2021 update. These are my disclosures. Today, I'll give an update on remdesivir because some new data were published just 2 days before this recording. I'll update you on the use of heparin for prevention of thrombosis in patients with COVID-19. Say a few words about a recently published budesonide study, and then review where we stand with the ivermectin follies. So let's talk about remdesivir. As you remember, remdesivir is an RNA-dependent RNA polymerase activity inhibitor with in vitro activity against a wide range of RNA viruses, and has been shown in animal models to have activity against MERS and against SARS-CoV-2, and has an EC50 of just under 1 micromolar in tissue culture systems. The ACT-1 study was a placebo-controlled trial that first demonstrated the clinical efficacy of remdesivir, and we've been through these data in the past, but just to remind you that there was a benefit overall, but that benefit really seemed limited to those patients who were receiving supplemental oxygen at the time of randomization, but had not yet progressed to high flow oxygen or non-invasive mechanical ventilation or worse, and was not so beneficial in people not yet needing oxygen. And then the Solidarity study showed that there was no benefit of remdesivir in terms of mortality, but a meta-analysis suggested that there might be benefit in certain populations, particularly when looking at non-mortality endpoints. So for example, proportion recovered, you see there was about a 10% benefit or advantage in terms of relative risk of recovering. There was also about a 30% reduction in the risk of progression to requiring mechanical ventilation or ECMO. And there was also lower risk of experiencing serious adverse events in these randomized clinical trials through this meta-analysis for people who received remdesivir compared to control. Well, now we have the Discovery study. The Discovery study was a phase 3 open label adaptive RCT conducted in Europe in the countries listed here. Participants were randomized equally to 4 different groups: standard of care, remdesivir, the combination of boosted lopinavir and interferon alpha, or hydroxychloroquine. This was a study that began really at the onset of the COVID pandemic and continued until January of 2021. Sorry for the omission on that date. And eligible participants were hospitalized with confirmed SARS-CoV-2 infection. They had to be on supplemental oxygen, and they had to be within 9 days of their initial diagnosis. The primary endpoint was clinical status at day 15 by a 7-point WHO ordinal scale. This slide shows the distribution of participants according to that scale at baseline and then at days 15 and day 29. And so you can see that at baseline, here red is worse than pink or beige and green. There's a relatively even distribution of disease severity among participants randomized to remdesivir or standard of care, and we're only looking at those 2 arms in this analysis. And at day 15, while fortunately the majority of people have improved, there's much more green here, we see that the distribution is still pretty even as it is at day 29. So whether you got remdesivir or standard of care didn't really matter very much in terms of the likelihood that your clinical status would improve. And that's seen in the actual statistical analyses where the odds of improvement at day 15 were just about even. At day 29, slightly favoring remdesivir, but not statistically significant. The one outcome that was significantly different in the secondary analysis was progression to a new requirement for mechanical ventilation or ECMO or death by day 29. There was about a 35% reduction in the risk of progression, and that was statistically significant. Sorry that the decimal point is missing on the lower limit of this confidence interval, and you can see the significant p-value here. However, there was no benefit in terms of mortality. The reason we talk about new mechanical ventilation is that participants could already be on a ventilator at entry, and that's a different issue than for some of the other studies we've talked about, like the ACT-1 trial, where people could not yet be on mechanical ventilatory support and enter into the trial. So where does that leave us with remdesivir? Really there are now a range of studies showing different outcomes. I think if we look at the meta-analysis, we have to recognize that for certain groups of people, particularly those who are early in the course of disease, but requiring supplemental oxygen, that remdesivir does have benefits in terms of preventing disease progression, perhaps in benefits in terms of a faster recovery and discharge, clearly no demonstrable mortality benefit overall, except perhaps in the subgroup who are on oxygen and not yet needing high flow. Well, let's turn to heparin. The REMAP-CAP group, combined with the ACT-4A study group and the ATTACK study group, published in the New England Journal of Medicine the results of their pooled efforts to study the use of either therapeutic dose or prophylactic dose heparin in critically ill patients with severe COVID-19. The primary outcome here was organ support-free days, again on an ordinal scale, and just under 1,100 participants were randomized to these two arms. What you can see here is for organ support-free days up to day 21. And I should mention this study was done using Bayesian statistics. And so we're looking at what was the posterior probability that an endpoint was achieved. And so here, the adjusted odds ratio for a benefit of therapeutic dose heparin compared to prophylactic dose heparin was 0.83, but failed to reach statistical significance. And the Bayesian probability that you would ever demonstrate superiority of therapeutic dose was really minimal, only 5%. And the probability of futility was virtually 100%. And the probability that therapeutic dose was actually inferior was 95%. And so for all of those reasons, the study was halted and declared to be futile. And prophylactic dose heparin is the way to go forward. Looking at major thrombotic events, there were low probabilities of demonstrating a benefit of therapeutic dose compared to prophylactic dose, and the same is true for any thrombotic events. Very low probability of demonstrating superiority for the higher dose heparin, and there were in terms of major bleeding episodes, there was a approaching significance probability that higher dose might be inferior. This slide from that, or these two figures from that publication, look at organ support days as this distribution plot and Kaplan-Meier plot. And here it's because we've talked about organ support days for a number of different interventions, these are slightly confusing graphs to look at because they always end up at 100%. And what we're really saying is looking at the stepwise increment for days. So here, people who have died get a penalty and are counted as -1 days, and then 0 means people spent no days free of organ support. And you can see that between these two groups, we start off at about 50% of the population. By the end of the 21-day period, you have to account for everybody. And there are somewhere between a few percent and 10% of people who spend between 0 and 21 days free of organ support. And that's how you ultimately get to 100%. But you see these lines never diverge in a significant way, and that when we look at the overall distribution, there perhaps a tendency towards some worse outcomes in the therapeutic group compared to the usual care or prophylactic dose group, but clearly showing that there's no advantage to using higher dose heparin to prevent thrombosis in people with severe COVID-19. Well, what about budesonide? Budesonide is an inhaled corticosteroid, and the PRINCPLE study was an open-label, controlled platform randomized clinical trial. Like so many of the studies we've been talking about, it examined many different interventions, but this presentation focuses on the budesonide results. Symptomatic persons with probable COVID-19 at high risk of progression. These are not yet hospitalized, well, not yet requiring oxygen. They may have been hospitalized, but not on supplemental oxygen, or they were outpatient. Were randomized to receive inhaled budesonide, 800 milligrams twice daily, or placebo, or other therapies, but we won't talk about those other therapies today. The co-primary endpoints are time to first self-reported recovery and hospital admission or death related to COVID-19 within 28 days, again analyzed using Bayesian models. And the primary analysis is limited to those with confirmed SARS-CoV-2. For those who were outpatient who had symptoms of COVID-19, in order to get them enrolled rapidly, they could be enrolled, but if they subsequently tested negative for SARS-CoV-2, they were excluded from the primary analysis. This slide shows the primary study result, and here we're looking at different endpoints. For the primary analysis, it's either time to first reported recovery, and because these are outpatients, this is self-report, or hospitalization or death at day 28. And what we see is that there was about a 20% greater likelihood of recovering compared to usual care. And once again, using Bayesian statistics, we're looking at the posterior probability, and it's a virtual certainty, 0.999%, that getting inhaled budesonide led to a reduction or a faster time to recovery. In terms of hospitalization, progression to hospital admission or death, there was a bigger reduction, 25% reduction, but that failed to achieve statistical significance. You can see here from the credible intervals, and in Bayesian statistics, we use credible intervals, not confidence intervals, and that fails to reach the pre-specified probability for superiority, which was 0.99, not 0.95. And then for secondary analyses, if we look at all participants, that confirms the results seen in those with confirmed SARS-CoV-2 infection, and in sensitivity analyses that looked only at concurrently randomized populations. Because the way this trial was done, the control group was not necessarily always contemporaneous with the group getting budesonide, but you could limit the analysis just to those who were concurrent, and you can see that it confirms the primary result. That result should be placed into context of the recovery trial, which looked at the effect of dexamethasone on 28-day mortality by level of respiratory support. And as you may recall, that study and the recommendations for use of dexamethasone and corticosteroids showed benefit only for those already receiving oxygen or among those already receiving invasive mechanical ventilation. And this was a mortality benefit, but suggested possible harm for use earlier in disease among those not yet needing oxygen. So how do we reconcile these two results? Well, remember, the recovery trial was using orally dosed or intravenously administered corticosteroids, dexamethasone, and then other studies used other corticosteroids, and they may well have had broad systemic effects, whereas budesonide was an inhaled steroid with presumably only minimal systemic absorption. And that may be why the use of an inhaled steroid in people who are not yet requiring supplemental oxygen shows some clinical benefit, whereas systemic administration of corticosteroids suggests possible harm. Well, I'd like to spend a few minutes talking about nonsense going on with ivermectin, which I term the ivermectin follies. Ivermectin is antimicrobial with broad anti-helminthic activity. It was initially approved for treatment of onchocerciasis and was really responsible for the eradication of river blindness in the campaign that was led many years ago, and in which Jimmy Carter had taken a major role after his presidency, and is now also commonly used in the treatment of strongyloidiasis. Ivermectin also has a number of veterinary uses for treating helminthic diseases in animals that are commercially important. In vitro studies have shown anti-SARS-CoV-2 activity, but only at high concentrations, IC50s of just under 3 micromolar. But there were some small clinical trials that suggested benefit, but these have not been confirmed in larger randomized clinical trials. So let's look at some of those data. Here we see some pharmacokinetic data showing what doses or what levels of free plasma ivermectin are achievable in people given various doses here as micrograms per kilogram, remembering that the approved or recommended dose of ivermectin is 200 micrograms per kilo weekly. So even when you greatly exceed that dose, there's essentially no real dose response curve here. You fall several logs below the required concentration for inhibition of SARS-CoV-2 as determined in those in vitro studies. In this modeling done by Schmidt and colleagues, you can see that whether you're giving 200 micrograms per kilo as a weekly dose, or even 60 milligrams every 72 hours, you just can't get up to the couple of micromolar concentrations that would be needed to be effective. And then in the study conducted by Lopez Medina and colleagues and published earlier this year in JAMA, you can see that looking at the cumulative rate of symptom resolution, there was absolutely no benefit of ivermectin compared to placebo. And there have been a number of meta-analyses published. I'll just focus on this one from Roman and colleagues, published in Clinical Infectious Diseases earlier this summer. There's also an extensive analysis conducted by the Cochrane group that comes to very similar conclusions. And what you can see is that if we look at mortality, there is a failure to achieve statistical significance, even though there seems to be a numerical advantage driven largely by this study. You see these studies all have relatively small numbers. The largest study was the Lopez Medina study that we just talked about. Looking at adverse events, these are studies that use properly dosed ivermectin, not using veterinary doses. There was no harm, but there was also no benefit in time to viral clearance, not surprising given how far below the IC50 the achievable plasma concentrations fall. Well, that hasn't stopped people from aggressively marketing ivermectin. This is a roadside advertisement in a town outside of Boston stating that this particular pharmacy has ample supplies of human ivermectin available for, quote, compounding. Why anybody would need ivermectin for compounding is beyond me, because there is no use of ivermectin other than for the treatment of helminthic disease, for which it doesn't require compounding, for which you really don't need very large doses. There's also a very amusing spoof of ivermectin that is posted on Twitter by the Lincoln Project, and I'll just I don't have the time to play that here during the presentation, but the tagline was "Join the herd," spelled as referring to animals. Talk to your doctor today if you think ivermectin is right for you, and you can see a horse here. So in conclusion, mixed evidence regarding remdesivir continues to emerge. There will be more analyses forthcoming. Anticoagulation in severely ill patients with COVID-19 should be limited to prophylactic dosing. Inhaled budesonide may provide some benefit to symptomatic patients not requiring supplemental oxygen, very different than the systemic use of corticosteroids in the same group of patients. And ivermectin has no proven role in the treatment of COVID-19 and should be avoided and instead use those therapies that have proven benefit, and better still, get vaccinated.